So in phase 2, we have desensitization, okay, and they will become refractory to subsequent stimulation, okay, and we will have flaccid paralysis of the muscles, okay, so they become weak, they become paralyzed. So in terms of the sequence, what we have is first muscles that move rapidly, okay, the eye and the jaw will be first affected, okay, these will be the first muscles to be blocked, okay, the eyes and the jaws, okay, and last muscles to be affected will be the limbs, okay, the hands, legs, and then the diaphragm, okay, the diaphragm, which is involved in respiration. So these are the muscles that will be affected in a skeletal muscle blockade. So then what we have is the giving suxamethonium or succinylcholine will cause initial fasciculation, okay, fasciculation, release of potassium, myoglobin, and also creatinine kinase. And this potassium release will be enough. Okay, this will cause a raise in the plasma potassium concentration by 0.5 to 1 millimoles per liter. And therefore, we have to avoid giving this drug in patients with paraplegia and burns, okay? Paraplegia and burns. So suxamethonium is an ideal intubating agent because of its fast onset, and also it has a short duration of action, and it causes good relaxation of the muscles. So these are some of the good points for suxamethonium, and that's the reason why it used to be called an ideal intubating agent, okay? It used to be. Okay, nowadays there are many other agents that can be used. So suxamethonium has a rapid onset, it has a short duration of action, causes good relaxation. And if we need to give a second dose of suxamethonium, we should give atropine, okay? Should give atropine because suxamethonium can cause a profound vagotonic effect, okay, which will cause a significant bradycardia. Okay, your heart rate will go down. Okay, your heart rate will go down because of suxamethonium. Okay, so we need to give atropine, okay, to counter the effect and increase the heart rate. Okay, so this is very important. So remember that atropine can be used to increase heart rate. Okay, it can be used to increase the heart rate. Because if your heart rate goes too low, of course, in the end, eventually you will die. Okay, your heart rate goes too low, you have bradycardia, and then subsequently your heart stops. Okay, so it stops pumping oxygen to the rest of the body, to the brain, to the heart, etc. So that will cause death. Okay, that's why if it goes down, one of the drugs that we can give is atropine. Okay, so depending on the situation. So remember DS to remember depolarizing and succinylcholine. Okay, the dose is usually 1 to 1.5 milligrams per kg intravenous. Okay, so for example, if the baby is for a baby, okay, if someone is 10 kilograms, so we give about 10 milligrams to 15 milligrams of intravenous succinylcholine. Okay, so that's just a mind stimulant. Okay, just to stimulate your minds. So try to think about how much do you need to give if the patient is 150 kilograms Of course, this is not 150, maybe more than that, maybe 200, 250. Okay, but how much do we need to give? Succinylcholine. So adverse effects of succinylcholine can cause increase in the intraocular pressure, okay, the pressure inside the eye. Okay, so this is not a good thing, okay, because some of you in the exam you will answer that certain drugs are given to increase the intraocular pressure. Of course, that's not true. We don't give a drug to increase the intraocular pressure. Okay, and this is an unwanted effect. It's an adverse effect. It is a side effect of a drug. So it's not a reason. It's not why we give patients a drug. Okay, so we never give a drug. Not that I know of. We don't give a drug to increase the intraocular pressure in a patient purposely. No, we don't do that. Okay, so this is an adverse effect of suxamethonium, an adverse effect, an unwanted effect, a side effect of suxamethonium. Okay, increasing the intraocular pressure. Secondly, muscle pains. Okay, so post-operatively, after the operation, in about 1/3, okay, more than 30% of patients, they will develop muscle pains. Okay, after being given suxamethonium pre-operatively. Okay, so pre-operatively we give suxamethonium, and then they develop post-operatively after the operation muscle pains. Thirdly, we have bradycardia, usually related to the first dose, which is an occasional problem in children. Okay, so you develop bradycardia, your heart rate goes down. Okay, choline apnea. Choline is succinylcholine actually. What we call the suxamethonium or succinylcholine. So succinylcholine we call it choline. Okay, so it's called choline apnea, causing stopping of breathing. Okay, no more breathing is called apnea. Ap means A means none. Apnea is breathing. Okay, so there is no breathing. If there is dyspnea, means we have shortness of breath. Okay, we have shortness of breath. That's dyspnea. Apnea means no more breathing. So you give choline, causes no more breathing. Okay, so it can cause you to stop breathing. Besides, it can cause your heart rate to go very low. Okay, so heart, lung. Okay, causes the heart to go to be very slow. The heart rate to go very slow, and then the breathing to stop entirely. So to be more specific or more detailed, for cardiovascular effects, it stimulates all the cholinergic autonomic receptors. Okay, all the cholinergic. So it's the nicotinic receptors on both the sympathetic and the parasympathetic ganglia, and the muscarinic receptors in the sinus node of the heart. So at low doses of suxamethonium, we can have both negative inotropic and chronotropic responses. Okay, so the heart rate will go down, okay, as I've mentioned previously, and these can be attenuated, can be reduced, okay, can be dampened by giving atropine, okay, also mentioned previously. So we can give atropine in order to overcome this effect of suxamethonium. With large doses, okay, we will have tachycardia, okay, instead of bradycardia. So at low doses, it causes bradycardia. It tends to cause bradycardia, but at high doses, it tends to cause tachycardia. Okay. And a prominent clinical manifestation of generalized autonomic stimulation is the development of cardiac dysrhythmias. Okay. So you have sinus bradycardia. So it will cause many forms of arrhythmias. Okay, arrhythmias or dysrhythmias. So we have abnormal rhythm of the heart. Okay, we have sinus bradycardia, we have junctional rhythms, okay, and ventricular dysrhythmias. Okay, ventricular dysrhythmias. Don't bother too much about this. Okay, hopefully we will learn more on this, a little bit more on this in the cardiovascular module. So this is just a quick recap of what we have learned previously. Okay. So we have the parasympathetic, okay, nicotinic, okay, and then the ganglion is here, okay, so acetylcholine here, and then muscarinic, M1 to M5 at the organ, okay, and then nicotinic and norepinephrine or adrenergic, okay, alpha, and also we have beta, so alpha 1, alpha 2, beta 1, beta 2, beta 3, all those, okay. So these are the main ones, okay, just a quick recap. So sinus bradycardia, which is another, this is what we have mentioned previously. So the autonomic mechanism involved in sinus bradycardia is stimulation of cardiac muscarinic receptors in the sinus node, okay. So we have in the heart, we have muscarinic receptors, okay. So when the action of succinylcholine will cause, due to its effects on the cardiac muscular receptors, okay, it will cause sinus bradycardia, okay. So in adults, this phenomenon, okay, this condition appears more commonly after a second dose of the drug is given, okay, approximately 5 minutes after the first, okay. So that's when usually we see the sinus bradycardia, and this is particularly problematic, okay, in patients with predominantly vagal tone, okay, such as children who have not received atropine, okay. So these are just some details to just help you in remembering sinus bradycardia, so no need to worry too much about the details, okay. This is more for second year or and fourth year students, okay, rather than first year students. But then you need to know a little bit on sinus bradycardia and know that this is an adverse effect, a side effect of giving suxamethonium. So as mentioned previously again, this bradycardia can be prevented by giving thiopental, atropine, ganglion blocking drugs, and non-depolarizing neuromuscular blockers, okay, non-depolarizing neuromuscular blockers, which we'll talk about shortly. And then another adverse effect of suxamethonium is nodal or junctional rhythms. And this is probably because of greater stimulation of muscarinic receptors in the sinus node, okay, sinus node in the heart. And this suppresses the sinus mechanism and allows the emergence of the AV node as the pacemaker, because we know that the pacemaker is supposed to be the sinus node, okay, the SA node, sinoatrial node. But then if you suppress that one, you will have the AV node as the taking over as a pacemaker of the heart, okay. So that will cause a condition called junctional rhythms, okay. So this is usually more frequent, greater after a second dose of succinylcholine, but it's prevented by prior administration of DTC, okay. So don't worry too much about these details, okay. Just remember that suxamethonium can cause nodal rhythms, okay. So the SA node, okay, sends contraction signals. So then we have the AV node here, okay. So sometimes the AV node in junctional rhythms, the AV node will take over the function of the SA node as the pacemaker of the heart. The other adverse effect is functional ventricular dysrhythmias, okay, due to increased in catecholamine levels after giving succinylcholine. Okay, and then we have other autonomic stimuli, such as because we know that usually we give suxamethonium prior to endotracheal intubation. So endotracheal intubation, low oxygen, hypoxia, hypercapnia, too much carbon dioxide, surgery itself, okay, this will be all cause further autonomic stimuli, okay, that might lead to the ventricular dysrhythmias. And also we might have to consider the influence of other drugs, okay, such as digoxin, digitalis, okay, antidepressants, monoamine oxidase inhibitors, okay, exogenous catecholamines, and anesthetic drugs. Okay, all of these can cause or potentiate ventricular dysrhythmia.